We are live.
Namaskar and good evening, everyone. I welcome you all for today's webinar on clinical updates in lung and breast cancer. And I would like to invite Dr. Jagdeep Singh, who is Associate Professor Medical Oncology at Ludhiana, for the welcome and introductory note. Over to you, sir, for the first slides.
Thank you, Mrs. Ekta. So I thank all the people who are part of this conference or seeing me. So thank you, Dr. Vidya, for sparing a time for this session. So it's a sincere efforts from your side because not being in still India, still you spared a time. So we will be taking our session starting from the lung and we'll be switching on to breast. So what are the clinical updates we have? We will be just discussing on that. So first session will be by Dr. Vidya Valdor. She's a clinical director at Forbes Cancer Care Onco Solutions based at the Bangalore. So she will be giving a lecture on talk of the town. You can say NGS, which is every time we say for patient in the lung cancer or sometimes even with the colon. So over to you, Dr. Vidya.
Thank you, sir. So, can I share my screen or?
Yes, ma'am, you can now share your screen. I just presented.
Okay. Thank you so much for this kind introduction, sir. And I'm very glad that it's a learning platform for me also, that I am being part of this event. And without much delay, I'll start my presentation. So I have been asked to talk. Can you see my slides?
Yes, we can see. I think you need to put in presentation mode.
Now it is in presentation mode.
Yes.
Yes. So I have been asked to talk about next generation sequencing, what are the implications and how to interpret an NGS report. So I've been given 15 minutes here. I will try to quickly go through the implications and try spending more time in the interpretation. So, as we all know, non-small cell lung cancer is considered as the poster child of precision oncology. We started off with EGFR as a driver mutation that was identified back in the year 2008. And so following that, we have several biomarkers which are driving this disease in small subsets of lung cancer patients. And this particular slide shows that we have more than 10 biomarkers where biomarker driven targeted therapy is possible in non-small cell lung cancer, and we are still learning, and there is a gray zone of about 30% patients where the disease is driven by only tumor suppressors and none of these driver genes. Definitely there must be something beyond. So as we do more and more profiling to understand the genomic architecture of non-small cell lung cancer, we are going to discover more and more biomarkers for this deadly disease, which presents often in a metastatic condition in advanced stages as it is highly asymptomatic. So what is comprehensive genomic profiling or NGS? So the word NGS, next generation sequencing, is a technology that evolved after Sanger sequencing. So since Sanger was the first technology, this becomes next generation sequencing as a colloquial. Now in next generation sequencing, you have hotspot panels where you only look at the specific mutations, like for example in EGFR you're only looking at 18, 19, 20, 21 and only those 23 common activating driver mutations. That is a hotspot panel. However, there are some rare mutations like delins in an exon 18 and few other rare exon 18 mutations or 20 mutations which might get missed out by a hotspot panel, for which you might want to do a comprehensive genomic panel. Similarly, when you take ALK rearrangement, you have EML4 as a universal partner known very well in non-small cell lung cancer. Nevertheless, if you have an option, an assay or a test where you can look at novel partners, then it becomes a comprehensive approach. ROS by birth, rather by discovery itself, it is not with one partner. It has more than one partner. Therefore, when you are trying to detect a ROS rearrangement, you are looking at more than one partner to address the ROS fusions. BRAF V600E is again a single point mutation. As we, similarly, we have distinctions where a hotspot panel and where it is a comprehensive panel, and why it is important to look at comprehensive genomic profiling. It gives you a better picture of the tumor heterogeneity as compared to the single gene testing or even a hotspot panel. And it's a single test where we use both DNA and RNA. And what you detect from these are, for RNA, often what is clinically approved in a setting from RNA is only gene rearrangements, that is gene fusions. Gene expression in today's clinic is not accepted because it's a very dynamic calculation and it will have several other confounding variables. Therefore, it never became a biomarker. So with RNA, you are able to detect gene fusions. With DNA, you have an umpteen number of things that you can address by looking at the DNA mutations. These are base substitutions, insertions and deletions, amplifications, deletions, then tumor mutation burden and microsatellite instability. So it saves cost and time as well as the tissue, and hence it's become the most commonly used technology in advanced setting. In many centers, it is used after standard of care has completely been exhausted. In few settings, people have started applying this in upfront. The reason, again, we will see later. So today, NGS has become one of the recommendations in international standard of care guidelines like ESMO, where they clearly state that in lung cancer and prostate, ovarian, and cholangiocarcinoma, routine NGS is recommended upfront as part of the molecular workup. So this is just an example. We all know, as we don't want to spend more time here. And how is NGS better than sequential gene testing or single gene testing? So a lot of health economics work has gone in there, where people have proven that NGS definitely saves time, cost, and it has much more positive predictive value in terms of clinical benefit. So you see here, sequential testing versus NGS, you have a much better predictive summary as compared to the sequential testing, because sensitivity wise, NGS is highly sensitive and specific, and therefore you are able to pick up the finer details about the biology of the disease when you look at NGS. Similarly, it goes on with other cancers. So as I mentioned earlier, what's the advantage that you get by doing NGS? Today, the lung cancer landscape is so heterogeneous, you cannot go one by one doing individual tests. Therefore, it becomes important to address all in one go, and NGS is the way forward to address this. So how did NGS become so clinically useful? Is because some of the clinical trials on precision medicine have clearly shown that when you do an upfront biomarker based therapy stratification, definitely you see a very good clinical benefit in terms of PFS and OS in patients with across all cancers actually. This is another example with non-small cell lung cancer, where we see that importance of biomarker testing upfront, how it benefits the overall survival. NGS interpretation. Now here I would like to just go back to some fundamentals. People can stop me, or can put some of their questions in the tech window or chat window if there is any query. So before we understand anything about NGS, it is very important to know the triplet codon table. That is, proteins are considered as the workhorse of the human cell, and any mutation in the protein will change its function. and therefore the disease comes. And that's a 99% of the time that is how disease comes. There is always another approach, that is DNA or an RNA based mutation can also be functionally relevant, and it might also lead to disease. At the end of the day, understanding the triplet code means each letter of three letters together is coding for one amino acid. What type of change that is happening? Is that change conserved, or is it important in the functional domain of the protein? Like, for example, EGFR, the kinase domain becomes important because that is the one which triggers cell proliferation. If you go to Ewing's sarcoma, the fly domain, which has the DNA binding, that becomes important because that is the transcriptional regulator, and that is the kind of the central phenomenon that happens, which is responsible for the disease. So depending on which biomarker you are looking at, what type of functional information that biomarker is giving has to be understood at a greater level. So a change in alphabet sometimes may not necessarily change the protein. So this is a 3 alphabet. TTC is also lysine. TTT is also lysine. That means when you say change C to T, essentially lysine remains lysine. These are called silent mutations. They don't give rise to any pathogenicity. But some mutations are there which will abruptly stop the protein preparation itself. These are very dangerous. These are pathogenic mutations. Some of the mutations change the amino acid. They are also equally sometimes dangerous, not always. If they are dangerous, they are considered pathogenic. If they are not very well characterized, but you have a suspicion that the change may be detrimental because it is there in the functional domain, it is called variant of uncertain significance. When it comes to insertions and deletions, we earlier saw, right, it is always in the multiples of 3. This is the nature's law. This law is the one which the disease also follows, the cancer as a disease. So if the insertion or deletion is happening as multiples of 3, the protein does not change drastically. That is why it is called an in frame, meaning you are not changing the frame of the alpha protein chain. Such changes essentially change the function to some extent by clipping the protein, and it will change it to an oncogene. Classical example is EGFR. Sometimes deletions can also happen, but if the deletion or insertion does not happen in multiples of 3, it happens like 2 or 1, then it is resulting in abrupt truncation. That is what usually happens in tumor suppressors like TP53, SMAD4, PTEN. These are the genes which always encounter going through termination, meaning the protein is not produced. So if your IHC is positive, does not mean there is a functionally relevant protein. It is just a protein which is not functional, it's lying inside the cell. So when you read an NGS report, the most important thing is, has the lab developed the test based on international recommendations given by College of American Pathologists, which again goes back to something called as ISO 15189. So this is one of the hallmark publication back in 2017, where people started using this as a guideline message to develop NGS test. Now, what are the important nuances which one clinician has to remember when an NGS testing is suggested? What type of sample is being provided to the lab to do the testing? We have several types of sample sources. The standard one is FFPE. Sometimes, rarely, it could be a fresh tissue, and a blood sample where you are using a WBC of the blood and you are looking at germline mutations, or you are using the plasma and isolating the cell-free DNA and call it as a liquid biopsy, and then you are looking at somatic mutations along with germline, of course. These are the sample types that you use. I think I am done with the time. Do I have 5 minutes?
No. You please continue.
Ah,
You must be very elaborate because This is the backbone for our
Yeah.
all the tests. This is what we are planning in our test.
Okay, sir. So the next point which everyone has to remember is what we feed in is what we get out. Garbage in, garbage out. If we are fundamental requirement, the input raw material itself is inadequate or insufficient, then you are not giving justice to the understanding of the disease. Suppose you had less tumor content. That means that you are not addressing the tumor's heterogeneity, multiple clones being present, or even the minimal requirement of tumor DNA to look for mutations that are driving this disease. So again, I'll show in the next slide. People generally use the word our lab has a 10% cutoff, 20% cutoff. See, 20%, 50%, 60% is a very relative term. So 50% cutoff in 100 cells is only 50 cells. Is 50 cells sufficient to do NGS testing? No. So along with this, one has to also look at how many malignant cells are present in that 2-micron HND slide. One has to have minimum of 150 to 200 malignant cells in a given high power field at 100x magnification. Like this, you have to have minimum 3 areas. So roughly in a given slide, you should have at least 500 malignant cells. Like this, you take 10 microns. So this is a very important factor, which is called the acceptance criteria, which every lab establishes by themselves when they do the validation. So the way in which they validate becomes a very important factor. Depending on that, only your diagnostic yield will change. Meaning for any given NGS test, how often you are getting positive result, how often you are getting null reports. So if your diagnostic yield is more than 80%, then you can be rest assured typically when you are looking at a small gene panels, because when you do small gene panels, you are missing out on tumor suppressors, which is a very big landscape because they are not useful in clinic. They are only prognostic markers. It is possible that when you look at a small gene therapy panel, you are only looking at what you want for treating the patient. But the bigger picture is what is causing the disease. The underlying cause could be a tumor suppressor. So that proportion, what contributes to the non-small cell lung cancer genesis, or for that matter, any other cancer, is that 30% of lung cancer patients who are wild type for all drivers. They essentially have some tumor suppressor being mutated because of which the disease has come in. So that particular, so a lab testing, so where I'm coming from is, if you have a panel, targeted gene panel, which could be comprehensive or which could be hotspot, if you are getting more than 75 to 80% diagnostic yield, that means you are not missing anything essentially. So that explains how important it is to look at tumor content before you start the testing. So something which has already been done in the hospital may not be sufficient. Every NGS lab does their own tumor content estimation before they start the NGS testing, because this block would have gone for multiple IHCs and multiple things. So a fresh HND section examination is very, very important. Or if a pathologist from the hospital side confirms that this block is raw and it has not been used for anything else, I'm giving you the assurance that this much tumor content is there, then the lab can take forward. Particularly when there is a tissue limitation like in non-small cell lung cancer, it is always better to have a connect with the pathologist and try to understand where we stand with the adequacy of the tumor. Now, scope of the testing, we already discussed earlier. What is comprehensive genomic profiling? What is the test offering you? Is it offering you point mutations or SNVs, insertions and deletions, amplifications and fusions? Or is there anything else that is it offering? If it is offering, what is the cutoff, limited cutoff? Like how many read or how many DNA fragments or how many cells carrying the gene fusion, if you have detected uniquely, will you call it as a positive result? That is an important cutoff a lab will establish. Similarly, amplification. How many copies is the minimum copy that you want to call? That above that threshold, I call it actually as a gene amplification. When it comes to mutation, Again here, how many cells are carrying this mutation? Here it is again a relative term, because how much you have fed into the assay is what you get it out. So generally in NGS, the limit of detection can go all the way up to 1%, no doubt, or even less than that, depending on how deep you sequence. We'll come to that later. Nevertheless, it also depends on how much of tumor cells you have input. So that is directly proportional to the sensitivity of the assay. If you have put in 100% tumor cells, you can expect an LOD of 1% sensitivity. That means out of 100 cells, at least one tumor cell must be carrying the mutation due to tumor heterogeneity. But if your tumor content, you are putting it as 10%, 20% cutoff, then you may or may not achieve that 1%. It depends on what kind of a sampling you have done. So on an average, globally, the CAP recommendation also says an NGS assay typically with an LOD of greater than 5% is clinically meaningful to consider, which has at least 10 reads to support and say that yes, it is there. Even some of the FDA approved assays like Foundation One, they look at what is the coverage of this NGS panel at 100x. If I take 100 reads on the different types of tumor cells which are present in the tumor sample, if I can pick up at least one cell that carries the mutation, that my LOD is 1%. But if I am able to pick up only 5 cells, then my LOD is 5%. Similar thing holds good for Handels also, means because they are also similar mutations. It's just that here one alphabet change will change the protein. Here 3 or 4 alphabets get either deleted or inserted. Okay, next important thing is what are the genes that are being sequenced in this particular panel. One has to look at the gene list, whether it is a hotspot or full gene covered. Hotspot comes with its own benefits and limitations. Full gene comes also with its, no limitation essentially. It comes with benefits of identifying rare driver mutations in any given patient. So the depth of sequencing, again, 250x is what is a minimum requirement given by CAP and even the NABL. And if you get beyond that, it is more the merrier. But you can't expect this 250x reads across the genes that you sequence. So it is called average panel depth. So sometimes due to different regions of the genome, certain regions may not be well covered due to something called as low complexity, meaning the region is full of GC, GC. In such cases, sequencing has some challenges due to PCR limitations. Such regions may or may not get well covered. That is natural phenomena, so we cannot work with this. The technology's limitation. In germline, on an average, in most of the labs in India as well as abroad, people go with more than 80x as an average coverage. However, when you go back to books are saying even if you are more than 30, 40x or 50x, you are good to go to look at germline mutations. So has the entire panel been well covered? When does this coverage become a problem? When you have a heavily fragmented DNA. I'll come to that later. Then we are also going to discuss about what way you want to make the reporting. Those mutations which have direct therapy option for the cancer is called tier 1. Those which are off-label therapy option is tier 2. That is available for other cancers but not in this cancer. Then we have prognostic information. So again, in the report, we have to always write about what kind of limitations which any given NGS assay has. As I told you, what you feed in is what you get out. If your tumor content is not a true representative, you may get false negative results. And most important, has the lab validated very well and has it gone in for a certification with NABL and CAP? Or either NABL or a CAP. So this is where I was talking about the, how different terminologies work. We have discussed this, what type of samples can come in. So this is the dynamics. So here, this is a big chunk and there is 60% tumor, okay? This is a small chunk, here also 50%. It's a very, very small chunk, but you are at 65%. So what is 65%? That becomes very, very important. That is why quantifying what is this 60% is a very important. So by looking at the block itself, one can visually examine and say, is this going to be adequate or not to take it forward to avoid false negative results in NGS? For that matter, in any molecular testing, of course, because it's important that we give the true information of the disease. So you have to take the right material. So again here, if you are able to carefully take only the tumor containing area and eliminate the stromal cells, you are enriching the tumor DNA. That way, again, you are increasing the diagnostic yield or the sensitivity of the testing. So this is what I want most of the clinicians to understand, because most of the labs will say assay failed due to several reasons. So on the top there is a germline, that is the WBC fresh blood DNA. It will be like a single peak around 10,000 bases or more than that sometimes, and there is no fragmentation. But if you see FFPE, this is a batch of FP samples coming from different hospitals in a lab when they did the DNA isolation. You see the shearing of DNA. So the black line is actually the DNA, which is captured by imaging. And this is the ladder, the lowest size of the DNA and the highest size of the DNA. So when you see here, the DNA has got highly sheared as it went through the FFPE block preparation due to all the chemical reagents that has been used. And we cannot avoid this because we are trying to preserve the tumor architecture, which is the histology or the pathology. And microscopy is the cornerstone for cancer diagnosis. And therefore, it is important that it has to go through this to preserve the 3D architecture of the tumor. So while it goes through, there are few ways where we can still preserve the DNA by changing the buffers, the quality of buffers that we use, time to fixation, time between the time the tumor was taken out of the body, to avoid any kind of a tumor lysis or in ischemia kind of thing. So these are the things which one has to remember. Here you see that there is different patient samples have different level of degradation, fragmentation. Among these, if you want to say the best is probably this sample, the rest are all like, on an average, they have heavily fragmented DNA. So this also has an impact on how you get your results. So this is again something called as NGS library. It's another quality control. If your DNA is not so much fragmented, like 1,000 to 3,000 bases, like we saw in the previous slide, you get a nice peak around 300 bases. So it is, again, I don't want to get into the technical details here. This is a kind of peak which will give you good quality data. But if this peak is shifting towards this side, 100, between 100 and 200, that means to say that the input FFP DNA that has gone in is a heavily fragmented FFP DNA, and therefore you have very high chances that you may not get good results. And as we said earlier about the DNA, now RNA. So as I told you earlier, what type of fragmentation, how much fragmentation is accepted. So generally, the kind of NGS testing that we do, the insert size is somewhere around 200 bases. Insert means the fragmented DNA that goes in for sequencing, essentially. So you essentially stitch the DNA fragments and try to infer the mutational data from comparing it with a healthy person's DNA. So what is the stitching size? Small size or average size is around 200 bases. So a 200 bases will give you a peak like this around 300. But if it was less than 200, like 100 or something, it will shift and you have a lesser chance of getting all the mutations well captured and good coverage. So with RNA, it is even worse because RNA is much more labile, prone to degradation as compared to DNA. Therefore, FFP RNA on average, the sizes are very, very variable. And if you are able to capture around 120 bases in FFP RNA, that is the best thing one can expect. But ideal, again, it goes to 300 bases, like what for the library again here. And in addition to that, the yield of FFP RNA, how much RNA you are getting, the amount of cells, what we discussed earlier, towards correlating to how much library you make in DNA is more or less you can have a feel. But when it comes to RNA, due to this degradation, you are clueless unless you prepare the library to the last stage and then look at the concentration or total number of unique DNA fragments that are available which can be sequenced. If your number of DNA fragments are less, essentially that is the concentration, then also there are high chances that NGS will not give you good results. So that is one of the important library QC or NGS steps which we take, and we report in the reports that due to this there can be false negative results. We need to be careful. So to avoid all this, lot of labs, including our lab, Foundation One, and several other designs have included looking for gene fusions at the DNA level by trying
Dr.
to,
Vidya, request you to conclude your talk
Yeah,
in the next
yeah.
minutes, please.
So this is what is called the depth of sequencing. I have explained to you. Each fragment you can imagine coming from different malignant cells, and you are trying to pile them on top of each other and look for the mutation that is of your interest. So this is the depth of coverage, and this is the horizontal coverage. So in this region, the gene is not very well covered. So as I told you, what is the scope of the test and what are the genes it is covering, and what type of mutations it's covering. That's an important aspect. And then, does that lab write about the depth of coverage? What is their cutoff? And what kind of analysis? This is more detailed, but when it comes to reporting, what kind of reporting guidelines does the lab adopt? And of course, we talked about what kind of contamination or limitation factors that can result in false negative results in NGS. So every test should also mention the limit of detection in either the limitations, disclaimers, or notes. Different labs have different way of representing. And one has to also write where the test is performed and has the test been accredited or not. So this I already discussed earlier. Tier 1 means directly relevant to the patient's cancer type. And tier 2 is you find a mutation which is relevant to another cancer type. Like suppose we found an FGFR2 point mutation. It is relevant in bladder cancer, but not in lung cancer. Then the representation comes here, the description comes here. Then when you write about a mutation, this is all about the details of the mutation. What kind of a mutational burden, what is the total depth, and what is the mutation depth, and what type of mutation. As I told you earlier, in frame means it retains more or less the structure of the protein. It might change the function from proto-oncogene to an oncogene. That's what happens with EGFR. When you talk about the truncations, these are the truncation mutations which are often seen in tumor suppressors. So when you talk about VUS mutations, so when do you call it a VUS? Meaning it's a rarest of the rare mutation. It is a somatic mutation found in the tumor sample, but it's not been well characterized. So who characterized it before us and what did they say? We have to quote that on either by article or from databases like ClinVar or CBioportal or OncoKB to say that this is where it has been mentioned. That way the clinician gets everything comprehended in the report summary. So when it comes to liquid biopsy, the situation is much more. The take-home message from liquid biopsy is even at 0.1% mutational burden for any actionable alteration in liquid biopsy is considered to be a good significant result. The reason is it is going into the ocean of the blood. So it is holistic sampling of all the primary and the metastatic sites where all the tumor DNA is released into circulation. Therefore, you will not be able to do the enrichment that you did with the tumor tissue here, and hence your allelic burden can be low. So another important factor which you must remember is what were the mutations identified in tissue and what were they identified in liquid biopsy at baseline, and what happened to those mutations in follow-up, and did you find new mutations in follow-up? In this case, NRAS was the baseline mutation, FGFR2 is the new mutation which came up during disease progression. Comparison when you do simultaneous profiling between solid and liquid. So it is very evident this 35% is happening because you have concentrated the tumor cells, you've taken the enriched tumor DNA. Whereas in the liquid, it is going into 5.5 liters of blood. So definitely it gets diluted. That is why you have to do deep sequencing. So over there, here, if you are able to pick up the mutation in 100 cells, you have to do more than 10,000 cells to pick up this kind of mutations. That is why it is called deep sequencing. And definitely there will be a reduction in mutational burden if you have taken upfront good amount of tissue. But sometimes you might have tissue being less, but still you attempted tissue. You might get more mutations burden in liquid biopsy. You should not come to a conclusion that there was less in the tissue. Does it mean that that site did not have enough clones? No. It again goes back to how much tissue was taken in NGS testing. So we cannot make, so this is a relative number. We need to go back and look at the tissue and then take a call whether it makes sense to directly correlate 35 versus 10%. So I think here I stop. If there are any questions, I would be happy to take. Otherwise, at the end of the session, if you want me to take, I can take.
Thank you, Dr. Vidya. It's a very elaborative. So this enrichment, sometimes we usually miss, we don't know about when we are taking the liquid biopsies. And that's why we have having more of false negative reports. Though the mutations are positive, but we are not able to pick in the liquid biopsy. This is one of the limitation when we are treating those patients, because sometimes we are not aware of this enrichment also in those samples, but it has been done and we don't even ask the pathologist. I think it's a very good session and it gives us a lot of knowledge to our this oncology. And basically, lung is a biomarker-driven disease in the metastatic setting, and even in the adjuvant setting. Now we have a lot of drugs which were initially in the metastatic, and it has gone to the adjuvant setting. Thank you for your this very comprehensive talk. So, anybody else wants to have a question with Dr. Vidya, please? Otherwise, we should to next topic. Dr. Puneet is there.
Yes, sir.
So, okay, next session will be by Dr. Puneet Batani. He's a consultant nuclear medicine at DMCH AOI Ludhiana. Dr. Puneet, are you there? So, I think
just see.
Okay. Yes, Puneet, over to you. This is your session for PET CT and chest, CT chest features when to choose for the lung malignancy. Over to you. You can take your session.
Okay. Thank you so much. Hello.
Puneet, you can share your screen and be very because
brief and
you are brief.
Yes, 10
because
minutes.
You have missed your session. It was your.
Yes, I was on the way. Please see if my slides are visible. I'll just hold on.
No, it's not visible.
Now, are they visible?
No.
So do you want me to share the slides?
Better,
or you do
better,
share the slides then?
Better, Yashika, you can share the slides.
Okay.
I'll just
So we can start.
Okay, good evening, everyone. I'll be speaking on a role of PET CT in carcinoma lung and how our PET CT modality can actually help our physicians and patients in finding out the best possible results as required. So topics reviewed will be basically basics of FDG staging, available evidence, pitfalls, and a few cases cases will be discussed. So next slide, please. Next slide, please. So basically, we are doing a metabolic imaging as well as anatomical use using PET-CT, which is a positive emittent using F18 labeled FDG. So FDG basically is a analog of glucose, and it is labeled with F18, and it is a it emits it is a radioactive substance, and we inject and do imaging after 45 minutes after good patient preparation, checking his creatinine levels, and doing all the basic formalities. So next slide, please. So this is the basic TNM8 staging for CA lung from T1 to T4, N1 to N3, M1 to MC. Basically, based upon the size and involvement of surrounding structures, as N1 will help us to tell us the nodal staging, as whether it is N1, N2, or N3, or M1 will help us to give information about the metastasis. This is the staging grouping from stage 1 to stage 4, as you all are aware. Next slide, please. Yeah, this is what I was talking about. The next slide, please. So basically, we need accurate staging and the accurate staging will help us in deciding the treatment, whether it will be surgery, whether it will be chemo followed by radiation, or it will be combined, and how it will approach the patient. One is we have the accurate staging. Basically, it is staged from stage 1 to stage 4, and based upon size, nodal involvement, and metastasis. Next slide, please. So this staging also help us to give us 5-year survival and from stage 1 to stage 4. So in basically, as the stage increases, the survival of the patient increases. So is our treatment modality. So this accurate staging is very important in all patients of CA lung. Next slide, please. So as per NCCN guideline, PET-CT is recommended in all stages of PET-CT from stage 1 to stage 4. This is just a flow chart which is showing, it's a busy slide. Just the basics is that we can use PET-CT in all stages. Next slide, please. So this is just a flow chart which is showing how and when we are using PET-CT. PET-CT can be used initially when the patient comes with a single nodule as a solitary pulmonary nodule. It can be used as initial staging. It can be used for nodal staging as well as metastasis. And it may use for response assessment. It gives prognostic information. And based on this, we use this flow chart. Basically, to have a T stage, an N stage. If N stage, we will discuss later, as well as metastasis, whether intrathoracic or extrathoracic. What if N nodes are positive or if nodes are negative? What are things to be done? We usually follow with mediastinoscopy, and we do biopsy and plan the treatment according to this flow chart. Next slide, please. So this is once we see that most of the patients who have come to us are usually 50 years and above, and usually smokers and have a high risk history. So basically, when a patient, there is a question arises in our clinical practice when patients come with solitary permanent nodule. There is a suspicion whether it is malignant or benign. So as per the criteria given by French Society and American Society, Chest Society, they said that its size should be around 8 mm or 10 mm. It is a deciding factor. If it is less than 8 mm, we just follow with CT or serial CTs. But if it is more than 8 mm, we assess the pretest probability, whether it is low, intermediate, or high. And then we follow it with serial CT or PET-CT. When in the possibility is between intermediate group, which is between 5 to 60%, and we see whether it is any PET uptake or whether it's positive, or it is if it is positive, we do further biopsy for that patient, and I'll do the histopath evidence and decide the further treatment. So because smaller lesions because of partial volume effects, will not be showing uptake. So PET-CT will not be useful for very small lesions. So basically, in solitary pulmonary nodule can present as solid lesions or ground glass lesions or adenocarcinomas in situ or adenocarcinoma hypoplasias. So bronchoalveolar carcinoma. So in these smaller patients which present with ground glass opacities, there PET-CT doesn't have much role. It is only when the size goes beyond 8 mm, then we are actually using this. So because these smaller lesions with ground glass adenocarcinoma in situ, PET-CT can result in false negative results. Next slide, please. So basically, we discussed T staging. CCT is the modality of choice. We do FDG PET-CT with contrast, and it gives a one-stop shop, which gives a complete information about the T staging. So what is the advantage over plain CT? Basically, CT will not be able to give an accurate T staging sometimes because of atelectasis, associated collapse, consolidation. We cannot delineate the boundaries of the tumor. Next slide, please. So So these are just different type of cancers based on the histopathology. We have a adenocarcinoma, which use high FDG uptake. It is usually periphery located. Next slide, please. Next slide. This is another patient with squamous cell carcinoma, which also shows good moderate FDG uptake, is centrally located. Next slide, please. This is a large cell carcinoma, which is basically having large nodes as well as the diffuse distribution. Next slide, please. Next slide. I think we have just wait. Okay, this is please go to the previous slide, please. This is just showing T staging because we are not able to see the accurate boundaries of the tumor. So here we are actually on PET CT, we can see how the malignant cells are there and what is the collapsed lung associated. So it gives us the accurate size of the lesion. Next slide, please. Similar lesion, which is not a T for T staging. Next slide, please. I think now a few of the slides are missing in your presentation, but either the updated presentation is not there. Anyway, basically we are looking for nodal staging. Nodal staging, we want N1, whether the disease is having N1, N2, or N3. So N1 basically or N2, it helps in deciding a treatment plan. So to have an accurate N2 or N2, 3, we use PET CT as the modality. PET CT has low positive predictive value, but has high negative predictive value. If it is negative on PET CT, that means we can there's no need to do a histopathological evidence. But if it is basically PET positive, so because of low positivity, we need to have a mediastinoscopy or histopathological evidence. Histopathological evidence in the disease. So in that way, we need to have both size as well as the metabolic information before deciding upon the end staging. So but many cases when the we have a tumor of but disease is PET negative. In those cases, the question is whether we should be doing histopathology and doing to see whether there is nodes are involved or not. So there are few indications where we can go for mediastinoscopy or histopathology evidence. When even if there is a PET negative on lymph node, when is there is the node size is more than 1 centimeter, and some literature they're more than 1.5 centimeter in short axis, or it is a centrally located tumor, or the primary tumor is having low FDG uptake. There's a few indications where even if PET is negative, you can do a mediastinoscopy and histopathology evidence. And if it is positive, then we should go for histopathology evidence to prove whether it is definitely involved. Sometimes because of in our subset of population, there is granulomatous diseases which actually cause false positive relations. Okay.
You have to wind in next 2-3 minutes, please.
2-3 minutes only. Okay,
Yes.
okay. Okay, please next slide, please. This is just showing a image which shows a PET N0 disease, but mediastinally it came out to be positive because of low FDG uptake. Next slide, please. Similar lesion with which came out to be N positive. Another lymph nodes which are positive on PET CT, but they came out to be granulomatous. Next slide, please. Next slide. This was the slide I was talking about. So this is just retrospective analysis, which only says that we need to histopathological evidence. Next slide, please. Just images showing where T2 N2 disease, where there is involvement of a lymph node. Next slide, please. Another T2 N3 disease where contralateral nodes are involved. Next slide, please. Yeah, next slide, please. This is a patient which we did only CT. When we did PET CT, we found that there was node involved in the N2 nodes were involved, mediastinal nodes involved. Next slide, please. For M staging, we know that PET CT is very useful modality for finding adrenal, bone, liver, and brain mets. So it is able to detect occult metastasis as the stage increases. Next slide, please. Adrenal mets is usable because adrenal is a common site of a focal lesion, intense FDG uptake, which can be metastatic. Next slide. This is just a slide showing adrenal metastasis. Next slide. Next slide. Bone metastasis, it will pick up bony lesions with lytic sclerotic changes or even without any CT changes on bone. So it is a very good modality for having a sensitivity specificity over 90%. Next slide, please. Next slide, please. It is useful for pleural mets. It will pick up pleural disease. The next slide, please. As this, you can see in this image, there are pleural lesions seen along the right hilar posterior plate. Next slide, please. This is another slide which showing pleural mets, costal media pleural mets with a large lung mass. Next slide. Brain metastasis can be picked up. It is in 50% of the cases we do dedicated PET-CT imaging for the brain by adjusting doing small field of view and higher MA. Next slide. Yeah, as you can see in this slide. Next slide. So it is useful for restaging for recurrent disease. In follow-up post-treatment, we can see smaller lesions in the lung when we are not able to differentiate between post-treatment changes and recurrent disease. Next slide. So this is so useful for response assessment. Initially, there was a disease which has responded well, and it gives us prognostic information. If there is high SUV initially in the PET scan, it shows the survival is less and there is a high chance of recurrence. And if high FDG is persisting even first or 2 cycles of chemotherapy, that means patient is showing poor response, and there is we need to change the treatment plan, and there is a high risk of relapse. Next slide. Next slide. Just these are just pitfalls where showing FDG lesion is there, but no CT changes. This is because of FDG embolus. Next slide. This is organizing pneumonia, which is having a mimic. These are basically I'm showing mimickers of carcinoma lung. Organizing pneumonia with speculative margins. Next slide. This is just a table chart for showing FDG avid and non-FDG avid lesions, which mimic malignancy. So these are chart which is actually very useful. We all should be aware of. Next slide. This is a support site FDG uptake, which was basically inflammatory. Next slide. This is a case of sarcoidosis where we use perihilar lesions of mass-like consolidated masses which can present. Next slide. Next slide. Aspergillosis, mucormycosis, which are vaginal granulomatosis. Next slide. These are basically hamartomas where there is a mass which calcification of fat attenuation, which is benign. So we must be aware of such lesions. Next slide. Tuberculosis. This is a cavitary lesion which peripheral inflammation, high intense FDG uptake, which mimics malignancy, which is commonest among CA lung patients or above 50 years. Next slide. This is just bone marrow reactivation coming because of chemotherapy. Next slide. This is carcinoid syndrome, which does not show uptake. Next slide. This is a granulomatous inflammation showing basically liver lesions as well as lung lesions. Next slide. This is a carcinoma lung with mediastinal lymph node, which are showing actually granulomatous mediastinal lymph node, false positive, basically. Next slide. This is carcinoid where Dotanov scan is done for a patient which shows intense FDG uptake. Next slide. This is Castleman disease where FDG uptake is seen and it mimics malignancy. Next slide. This is solitary fibrous tumor. That's the last few slides are left. We'll just see next slide. And this we just pleoforming adenoma. Next slide. Solitary fibrous tumors. Next slide. Just beyond FDG, a few new tracers which are like C11 methionine FLT, which is useful for a treatment response as well as to differentiating benign and malignant. So next slide. So just final. This is the final take-home message, which I'll be just So PET-CT is recommended in all stages of carcinoma lung. So it is coupled with CCT is a one-stop shop. So it is a high diagnostic accuracy, high negative predictive value for mediastinal lymph nodes. If they're positive, we need to have a histopathological evidence. For N2 disease, basically, if it is a PET negative, basically for a central tumor about hilar lymph node, larger mediastinal lymph nodes, and with low level uptake, we extend go have a histopathology evidence even if it is PET negative. So it is helpful in distance metastasis. It is helpful in assessing recurrent disease, treatment response, giving prognostic information, having a better target volume for radiotherapy planning, and it is also useful for solitary nodules which are more than 8 mm in size. So false negative can occur in PET-CT like in which show low FDG uptake like adenocarcinoma in situs and bronchoalveolars and smaller lesions are there. So there are many other cases where we can mimic malignancy as discussed, and like amyloidosis and other places also. Thank you. Thank you for your time. I think I've finished my slides.
Thank you, Puneet. Actually, you were already late before, man. That's why.
Sorry, I think I've. Hello.
So you got late initially to start, so we were waiting for you from last long time. Anyhow, thank you
Yeah,
so
yeah.
much.
Again,
Next
thank you so much.
topic is with redefining treatment landscape in the non-small cell lung cancer IM-powered trial. So over to you, Ritish.
Thank you, sir, for this opportunity and the introduction. So I'll be sharing my presentation. So basically, in the present era of immuno-oncology and precision medicine, we are moving away mostly from chemotherapy. So my presentation will be basically sticking to what Tecentriq has given us in the last couple of years. So this is the disclaimer. So basically, it is for us itself. So if we see what are the treatment options which are available for metastatic non-small cell lung cancer, who those patients who do not have a actionable mutation. So there, first line chemotherapy, second line is chemotherapy plus cancer immunotherapy or chemoimmunotherapy or immunotherapy alone is an option. So most of these options have been explored now and have been under scrutiny, being evaluated, and has shown a greater response in those patients where we lack actionable mutation. So this is the journey of atezolizumab. Initially, it was approved in second line with Oak trial in 2016 in US and 2017 in India. Then moved on to the first line where I am PAR 150, where ABCP was the regimen which was used. Again, first line where I with in the IAMPAR trial where it was used with the carboplatin plus nab-paclitaxel with the atezolizumab or without atezolizumab. Then in the first line comparing immunotherapy versus chemotherapy, IAMPAR 110. So then nowadays it has a role in adjuvant setting also, where it has been used in a uh, resectable CL lung post chemotherapy and has been compared with best supportive care. So I actually don't think it is a best possible trial design which has been developed here because of the comparison with the best supportive care as a other arm. But definitely there has been some benefit for those patients. So quickly, so these are the basic outlines as I have told you. So I am par 110 atezo versus chemo in squamous or non-squamous carcinomas where it has been compared. Second is IMPAR 130 where it is atezo plus carbo and nab-pacli versus carbo plus nab-pacli plus placebo, but only in non-squamous variety of lung cancer, and the IMPAR 150 where it was a three-arm trial, atezo plus chemo plus bev. The third one was chemo plus bevacizumab. So
Ritish, we means the
yes,
time you must be in
so
the time limit, sir.
yes, quickly we'll go to the trial. So this trial we have been listening to for the last couple of years. So it is IMPAR 110 stage 4 non-squamous or squamous metastatic NSCLC patients, PDL1 selected high patients where they were EGFR, ALK, ROS negative, randomized to atezolizumab versus chemotherapy arm, continued immunotherapy versus chemo stopped after 4 or 6 cycles till disease progression. The primary endpoint was overall survival. The secondary endpoint was progression-free survival and the overall survival. So the fairly well matched baseline characteristics, and also there was a Asian subgroup which was included in these patients. So if we see in patients who have high PDL1, there has been a dramatic improvement in the progression-free survival. So the hazards were 0.59, so 31% reduction in the progression-free survival when it was only immunotherapy arm compared to the chemotherapy. And at 20 months, there was a absolute improvement of approximately 7 months. So Coming to the same analysis, again, the PFS has been prolonged uh, by 2 to 3 months here. So in this chart here, we see the overall response rates were more by delta of 12%. Then the PDL1 was also assessed with the other methods by DECO 22C3 and SP263, which also showed that there were a benefit with only atezolizumab versus chemotherapy. So there was no new safety signals in the trial. The grade 3 and grade 4 side effects, which were immune related, were seen with atezolizumab, which was arthralgia, pruritus, and hypothyroidism. Others were almost the same, or rather less nausea, neutropenia, and anemia. So this is basically the summary of this trial says it is also a positive study which shows a significant meaningful improvement in the overall survival, which was approximately 7 months, and improvement in the progression-free survival in a high PDL1 population. So with no increased or aggressive safety signals. So coming to IMPAR 130, where it was compared with chemotherapy, with or without atezolizumab in the first line, non-squamous non-small cell lung cancer. So non-small cell, so this was the basic trial design where maintenance atezolizumab versus PEM or best supportive care was continued. So the atezolizumab was continued till progression or loss of clinical benefit. The primary endpoint or the co-primary endpoint was investigator-assessed PFS in the intention to treat population or and the overall survival in an intention to treat population. So we know how cancer immunotherapy, when combined with chemotherapy, works. It increases the release of cancer cells, antigen presenting cells present the antigen priming of the immune related cells, increase in the T cell infiltration into the cancer cell, improve the tumor microenvironment filled by cells, and the recognition of these cancer cells by the T cells, and killing of the cancer cells, which is mediated basically by the immunotherapy. So this is the whole chart here. So this Tizentric, and we know why we should suppress the limit the use of steroids here, and hence the preparation by nab-paclitaxel, which was used instead of paclitaxel. Fairly well matched characteristics. And again, when we look at the progression-free survival here at 12 months, the progression-free survival was approximately double compared to the chemotherapy arm, and the hazards for disease progression was reduced by almost 26%, 36%. So the benefit was sustained throughout the chart here, only except for the patients who had liver metastasis at enrollment and those who were never smokers. So never smokers was the question that why the confidence interval crossed unity. And in the patients who had liver metastasis, the improvement was not that great, and the hazards were 0.93. Otherwise, it has responded even in low PDL1 population. So atezolizumab addition does benefit to the patients. So again, an improvement with atezolizumab in the intention to treat population at 1 year, it is 63 versus 55. At 2 years, it is 39 versus 30%. So a delta of 9% at 2 years, which was shown. So the hazards of there is a reduction of death by the percentage of 21. So the overall benefit was observed across the group, as I told. So the liver metastasis was the only subset where the response was not great. So coming to the response rates, the response rates have been great when it was combined with chemotherapy. So again, the safety summary, there were no increased safety signals in the atezolizumab plus chemotherapy arm. So coming to the non-squamous non-small cell lung cancer IMPAR 150 study, which is commonly used as a ABCP study. So again, it was a similar kind of a design with three arms. Arm one was atezo plus chemo. Arm B was atezo, chemo plus bevacizumab. Arm C was chemo plus bevacizumab, followed by maintenance atezo, atezo bev as maintenance versus bevacizumab as maintenance. So in this trial, the atezo only arm was actually not completely evaluated, and arm B and C was evaluated. Though it was left off because the responses when they compared with arm C were not that great. So these were the baseline characteristics, and please have a look at this. There were 14% of the patients who had upfront liver metastasis, and in this trial, more than 10% of the patients, approximately 11 to 10% of the patients, had ALK or EGFR mutations. So those patients who had progressed on targeted therapy have been included in this trial. So if we compare the overall survival benefit, there has been absolute delta of 20% in the overall survival benefit. The hazards, the risk of death has been reduced by 20% when this uh, the combination has been used compared to only bevacizumab plus chemotherapy arm. So otherwise, the delta is 9%. So there is a meaningful improvement in the median overall survival of 4.5 months. So across the intention,
Dr. Nitish
subgroup,
requests you to conclude your talk in the next 3
yes,
minutes.
yes. So across almost all the three groups, intention to treat population, high PDL1, low PDL1, and PDL1 negative, it has shown a greater overall response rate, and also the duration of response was longer. So, so PDL positive, PDL1 negative. So the PDL1 negative, the graph seems to be overlapping each other, but when we see the PDL1 population, which are more than 1% positive, the graphs are separating from the beginning, and that plateau continues even after 42 months of follow-up. So coming to the EGFR, where patient has progressed on EGFR TKIs, so they have shown a greater benefit with the hazards of hazards ratio of 0.59. The risk of progression has been reduced by 41%. So, so similarly here, the arm A and arm C does overlap, but when we compare with arm B and arm C, there is an improvement in the median overall survival in the post EGFR therapy. So same the overall response rates and the duration of response. So looking at the upfront liver metastasis, there is significant improvement in the overall survival. At 18 months, it was 23.3, the progression-free survival, it was 23% versus 2% at 18 months with only chemotherapy plus bevacizumab. So definitely in the intention to treat population, there was a benefit. But the benefit was short-lived, and after about 3 years, the graphs overlap. But when we compare atezo versus bev with chemotherapy alone, not in a combination, the graphs overlap continuously. So this combination does benefit the patients who have upfront liver metastasis. So this also showed the sum of the longest diameter in the metastatic site. So high burden, low burden disease was also compared. So then coming to the summary of all the three trials, so atezo monotherapy in the high PDL1 and has been shown a greater benefit. IMPAR 130 was atezolizumab plus chemotherapy in the non-squamous histology, potentially a steroid-sparing regimen. The PDL1 expression more than 1% has shown a greater benefit there. And then the ABCP arm, specifically for those patients who have progressed on TKIs, liver metastasis, and a bulky disease. So the last point I would like to comment upon, this is the newest most trial in the atezolizumab arm, where it has been used in the adjuvant setting post chemotherapy in a resectable tumor. Upfront, the stage was 1 to 3. So the patient's the primary endpoint was investigator-assessed disease-free survival. So it was a hierarchical design where it was assessed in this way: PDL1 higher PDL1 population, then stage 2 to stage 3A, Then it was DFS in the intention to treat population from stage 1B to 3A, and then the intention to treat population. So, so they had both squamous and non-squamous histology, and high PDL population was on a higher side, 54.5%. So here we can see that definitely the graph starts separating, and in the stage 2 to stage 3 population, there is some improvement, but the trial results are still awaited. These are all the preliminary data which we have at present. So almost everywhere the response has been there. The low T the PDL1 expression less than 1%, the response has not been that great. Otherwise, the responses have been great. So in even the DFS in the intention to treat population is there where the atezolizumab arm says not reached, and where the best supportive care arm says 37.2 months. So the further analysis, they have planned formal 5 overall survival analysis. So these are awaited. So interim analysis shows that the number of events in the atezolizumab arm are less, and definitely it does improve the initial disease-free survival analysis. But yes, the final overall survival benefit remains to be seen. So the last the chart here, the Kaplan-Meier curves are just overlapping each other, so we are not very sure about the data because this is just an interim analysis. I would like to look at the complete analysis and then formulate an opinion. How does atezolizumab work in the adjuvant setting? So again, based on the biomarker status, so where there are EGFR included and not included, definitely those patients who have EGFR mutations, the responses are slightly lesser, and I would like to prefer osimertinib instead of Tecentriq. So no new safety data, and also the number of doses were approximately 16 which were received by the patients. Tolerance have been good. 63% of the patient could complete more than 16 doses. So no new signals in the safety. So this is the this is the NCCN guidelines where they comment that high risk patients chemotherapy should be followed by atezolizumab even if the margins are negative. So atezolizumab in high risk patients, high risk are those poorly differentiated carcinoma which are not evaluated for the nodes which are the disease is bulky. So there we tend to prefer atezolizumab, but in presence of EGFR mutation, it is better to go ahead with osimertinib. So thank you.
Thank you, Nitish. Maybe the OS data will be more able to define what exactly we want to do, because
Yes.
as you see in the previous metastatic settings, this atezolizumab was used patients who were exposed to the either sort of TKI or this osimertinib. So they did pretty well in the metastatic setting. But OS data, the number of patients with this mutation and how they are behaving will be able to more define better whether we shall use this drug or maybe the osimertinib in the adjuvant setting.
And definitely the trial design is still tricky, not
Yes.
comparing with the osimertinib
Yes.
in case it is the EGFR positive.
Yes. So
And
ideally,
other
that
thing
could be a
is-
better trial design to define which is a
Yes,
better drug
yes.
and better therapy for those.
Yes.
Thank you
And,
so much, Nitish.
definitely there will be some new adjuvant arm, I believe. Thank you.
Thank you so much. So next will be Dr. Kanika Sharma. Are you there, Dr. Kanika? Yes,
Yes,
she's
sir.
there. Thank you so much. So Dr. Kanika, she's a consultant medical oncologist at Max Mohali Hospital. So she will be giving talk on updates in the treatment of adjuvant of osimertinib in non-small cell lung cancer. Over to you, Dr. Kanika.
Thank you, sir, for inviting me for today's session. And as we are discussing the latest advances, so I'll be talking about the updated ADAURA trial data of the OS. So as in the previous slide, we were discussing that we have to wait for the atezolizumab. Thankfully, in this, we have a long-term data for DFS, and now we have OS data also. So first slide I would like to correct. So this is maybe a US data that 1 in 3 patients present with resectable disease. In our practice, maybe 1 in 8 patients, they present. Most of them are 3B onward disease that locally advanced they present. So it is the leading cause of cancer death, accounting for more than 1.7 million deaths annually. And the deaths, number of deaths, they are comparable to the breast cancer, prostate cancer, and the colorectal cancer combined. So they represent non-small cell variety. They comprise 85% of the all lung cancer cases. And in this, 30% of them, they present with the resectable disease. So when we talk about the localized, that is 1B, and regional and locally advanced is stage 2 and 3A. So initially, before 2020, the standard of care in the early resectable lung cancer was surgery is the primary treatment, followed by adjuvant cisplatin-based chemotherapy, and the absolute OS benefit of 4 to 5%, as we have seen with the LACE meta-analysis that was seen in these patients. And then the patients were kept under follow-up. So till 2020, it was like one size fit all strategies for all the patients. But as we can see, the recurrence rate, it increases as the stage increases for these patients. So if the patient is 1B, then the 5-year recurrence rate is still 45%. And as it increases, it goes up to 76%. So it is basically like a ticking time bomb. We are just completing the treatment and then waiting for the disease to come back. So the results, they have shown an OS data, but the overall disease recurrence and death following surgery and chemotherapy remained high. So based on the limited numbers of study that was done in the EGFR mutated settings, So as we can see, in this study also the 30 to 40% of the patients were Asian. And as we know that the EGFR mutation is relatively higher, the percentage. And in the early stage also, when we see as per the stage 1, 2, 3, 4, then as compared to stage 4, even them, the EGFR rate is high, that is around 30 to 50%. So if EGFR TKI is available in the resectable setting, a similar proportion of the patient may be able to benefit if we do the testing upfront for all the lung cancer patients. So now coming to the ADAURA trial, that is the osimertinib as adjuvant therapy in the patients with stage 1B to 3A mutation. So coming to the study design, it was done in a completely resected stage 1B to 3A patients with or without adjuvant chemotherapy. So they have taken more than 18 years of age with a performance status of 0 and 1, confirmed non-squamous histology with exon 19 deletion or L858R mutation. Brain imaging was mandatory if not done previously, and a complete resection with negative margin. So the time interval they have taken is 10 weeks if it is without chemotherapy, or 10 weeks after the completion of the 4 cycles of adjuvant chemotherapy. So they have stratified based on the stage, which type of EGFR mutation, and what is the race of the patient, whether it is Asian or non-Asian. So they have 1:1 randomization was done in osimertinib 80 mg and the placebo. So the planned analysis was disease-free survival, and the treatment was continued until the disease recurrence, treatment completion, which was 3 years of the planned treatment, or discontinuation if any of the side effects or because of the other reasons. So the primary endpoint was disease-free survival in stage 2 to 3A patients, and the key secondary endpoint was in the overall population, OS, and the health-related quality of life. So when we talk about the baseline characteristic, so we can see it is equally distributed between the both arms. 2/3 of the patients were female in the average age group of 64, and again 2/3 was Asian, and it was equally distributed. So most of the patients were in 1B, 2, and 3A disease bracket. So the mutation and the 60% of the patient, they received adjuvant chemotherapy, whereas 40% of the patient, they did not receive and directly taken up for osimertinib after surgery. So when we see the primary analysis that came first, the DFS benefit. So this was primary analysis was done at 22.1 month. At that time, 60% of the patients were still on treatment. So this, beautiful graph separating with a big gap between the two graphs, it was still questionable, because what will be the further outcome when the disease tablet is stopped after 3 years? So this was not taken well that seriously, and it did not become standard of care. But we can see that there was an 80% reduction in the risk of recurrence with the addition of osimertinib for 3 years. We can see in the stage 2 and 3A population also, and the overall population also. Then they come up with the updated DFS that was done at around 44.2 months, when most of the patients, they have completed 3 years of therapy. And after the completion also, we can see that till 5 years also, the graph is separating very beautifully with a very significant difference between the two arms. And when we see the median DFS, it was 65.8 months versus 21.9 months with placebo, and still a hazard ratio of 0.23 that was seen. So this slide was also depicting that when it was done initially also at 22 months, and there was not much difference when a further updated analysis was done, still the difference was there between the two graphs. So considering in the overall population also, the difference is there. So when we see this forest plot, even in the subgroup analysis, the benefit is seen across all the subgroup, whether it is divided based on the sex or the age of the patient, even with the smoking history also in the patient who have EGFR mutated, Asian and non-Asian population, stage. So the maximum benefit is with 3A, but even in 1B and 2, the benefit is, evidently there. And even in the patient who have received adjuvant chemotherapy, still beyond the benefit of chemotherapy, there was an added benefit with the addition of osimertinib. So when we talk about the pattern of disease recurrence in these patients, so the most common in both the groups were lung, lymph nodes, and the CNS. And the CNS metastasis, this 83% was seen after the completion of the treatment. So when we can see, it was significantly less in the osimertinib arm, but the order of the site of recurrence was same between the two arms. Sorry. So when we talk about the CNS disease-free survival in patients with stage 2 and 3A, we can see that the 63 patients, that is 22 in the osimertinib and 41 patients, almost double in the placebo arm, they have CNS disease-free survival events. And 3% 3 patients were on treatment at the time, and the remaining all, they developed CNS recurrence after the completion of therapy. So when we talk about the overall survival data that has come up recently, so we have seen that with LACE meta-analysis, the absolute benefit was up to 5%. And in this, the adjuvant osimertinib beyond chemotherapy, they have demonstrated an absolute benefit of 12% at 5 years. So as we can see with the osimertinib, the 5-year OS rate is 85% as compared to the 73% with the placebo arm. And even in the overall survival also, the hazard ratio is 0.59. That is the 50% reduction in the risk of death is seen with the addition of osimertinib for 3 years. And still the absolute benefit is around 10%. So even if we see as we have previously seen with the disease-free survival, if we see in the overall survival according to the disease stage, so in the 1B, so as the stage progresses, the benefit also increases with each passing stage. So with stage 1B, the benefit is around 6%, but as we go further on the 8% and around the difference is significantly higher in stage 3A, in which we have already seen that the 70% recurrence rate is there if we have not given any treatment beyond chemotherapy. So when we see the subgroup analysis for the OS also, that irrespective of whether the patient have received chemotherapy or what type of EGFR mutation is there, the benefit is there with the addition of osimertinib. So when we talk about the subsequent treatment that was received in both the arms upon progression, so 22% in the osimertinib arm and 54% of the patients in the placebo arm, they have received a subsequent treatment after the initial 3 years of treatment. So as we can see, around 43% of the patient in the placebo arm, they have subsequently received osimertinib, and still there was a benefit in the OS seen. Even so, this can interpret that the early addition of osimertinib is better as compared to waiting for the recurrence and then starting osimertinib in the recurrent setting. So safety analysis, there was no new adverse event that was noted. The most common as seen during the previous data also, it was rash and the diarrhea that they have reported. There was 13% incidence of the discontinuation that was seen with osimertinib as compared to the 3% in the placebo arm. And all grade toxicity was higher, that is the grade 3 and above, 23% as compared to 14%. But they were well manageable, and there was no additional serious adverse event that was seen in the osimertinib arm. So coming to the conclusion, in the DFS analysis of osimertinib versus placebo trial, there was a 77% reduction in the risk of disease recurrence and death in stage 2 to 3A population, and a 73% reduction in the overall population. Whereas when we come to the OS data, so the hazard ratio is 0.49 with a 50% reduction in the risk of death. And it was consistent across all the subgroup, including 1B to 3A. And the safety benefit was also consistent with the previous data. So now there are multiple various other trials that are coming up in this setting. That is, they are checking about the tumor and the circulating tumor DNA to measure the measurable residual disease after the patient has undergone a complete resection of the tumor, to see which patient will have a more benefit with the addition of a subsequent therapy. The new adjuvant osimertinib in stage 1A disease. So till now that percentage is only 8%, but again the mature data will come. And again, they are also seeing whether increasing the duration from 3 years to 4 years, where there will be an added benefit of increasing the adjuvant treatment in the higher settings. So thank you so much.
Thank you, Dr. Kanika. So this osimertinib started this journey from the second line in the metastatic setting, going to first line in the metastatic setting and taking a place in the adjuvant setting. And later on now will be in the NSCT setting. Yes. The thing is that we are not getting much patients in the resectable state. I think if you ask me, 90 or more than 90% patient will be either metastatic setting, first line or second line. I hardly see patient who comes to me with post-surgery or post-resection. And adjuvant chemotherapy, I think I have not given in my setting from last 4 years. I was given in only my during DM days. So thank you for all this update.
I think it is like a coincidence or something, but right now one of my patients is receiving adjuvant nivolumab, and one of the patient has completed adjuvant cisplatin vinorelbine and EGFR positive for adjuvant study.
Similarly, nivolumab has already taken a place in the new adjuvant setting. The patients who are,
and the benefit is higher with the nivolumab as compared to osimertinib.
So that's why this shift from metastatic to adjuvant and later down to new adjuvant is a very you can say promising, and basically the patients who are getting all this therapy, and definitely the DFS, if you see updated, is also again a difference of 40% at 4 years. Yes. And overall survival again is it's a statistically significant. So really these drugs are done very well in the CA lung, and that's why lung is a basically biomarker driven. Means you can do this test at the start of the disease also, irrespective of the stage, not only metastatic or stage 3B or 3-2. Even I think when you get the diagnosis of stage 1A also, you have to check up for all the biomarkers in the CA lung.
So I was reading one letter to editors, so that's why they were giving a justification for increasing it to 5 years. They were saying that eventually they will recur, but by 5 years we will have more medicines in lung cancer, by which the speed the discovery is happening. Yes. So that's it.
Yes. Thank you so much, Dr. Kanika.
Thank you, sir.
So next session will be by Dr. Kunal Jain. Dr. Kunal Jain, sir, are you there? Sir, Dr. Kunal Jain, everybody is aware. Sir is my senior. He is heading my unit over in medical oncology in DMC Ludhiana. So, sir will take a topic on evolving landscape in of CDK inhibitors and implication for the clinical practice. Over to you, sir.
Good evening, everyone. Thank you, Dr. Jagdeep and Team Horizon for giving me this invitation and for this talk. I hope the slide is visible and voice quality, I hope, is okay. It may not be
Visible, sir?
But I'll just, yeah, okay, great. So I'll switch off try to switch off the camera if it is possible. Okay, so as about over the next 15 minutes will be about CDK4/6 inhibitors and mainly in metastatic setting. So the slides mainly have been provided by the Novartis. I have just made it a couple of additions in the end. So we all know that from the patient's perspective and from our perspective, the ultimate goal for managing any disease is better overall survival or improving the survival, and also maintaining their quality of life, especially when we are talking about metastatic disease and diseases where for a longer duration. And overall survival so we see that diseases where we have converted them to
Sir, your voice is breaking.
kind of
Means you can switch off the camera, I think.
diseases. In oncology, we are also taking that is what okay, so is it? I hope it is better.
Yes, it's better now.
Okay. So coming to the topic that whether CDK4/6 inhibitors are game changers in this setting of managing patients with HR positive, HER2 negative advanced breast cancer, we are aware about the three molecules that are available for use, which are ribociclib, abema, and palbo, and their trials, Mona Lisa group of trials for ribociclib, Monarch for abema, and Paloma trials for palbociclib. And all these studies have used their parent CDK4/6 inhibitor with a comparator or companion drug being either aromatase inhibitor or fulvestrant, and they have been compared with a single agent. So we are all aware about this data of PFS benefit, very impressive improvement in progression-free survival with all the molecules, almost a significant or rather a similar kind of magnitude of benefit, and with hazards close to 0.5 to 0.6 in terms of progression-free survival. So there has been difference in terms of patient population in all the trials and how they define endocrine resistance and their inclusion criteria. We'll not talk much in detail about that, but I think that is also something to be kept in mind. But the key point is that the progression-free survival, which is kind of similar in all these trials, is not translating into significant overall survival, especially in the case of palbociclib. And we know now that the palbociclib molecule is available as a generic drug, and which has kind of extended its horizon of use. But this is the one drug which has not shown overall survival benefit as compared to the other drugs like ribociclib in all the three trials, and abema has shown in Monarch 2 in first and second line in combination with fulvestrant, whereas the data for Monarch 3 is overall survival still is pending, and we have adjuvant use of abemaciclib as well. So as of now, the only drug which has shown or to be of benefit in terms of showing significant overall survival benefit is ribociclib, where the hazards are almost 0.7, 0.75 in all the trials. So again, this same question, whether the PFS benefit, if we are seeing with all the drugs, can that be taken as a predictor for overall survival, and why it has failed possibly in the Paloma trials? As I said earlier, that it may be difficult to show overall survival benefit with all the molecules, and it is considered, PFS is considered a good surrogate in majority of the oncology trials. But obviously, the holy grail is achieving benefit or improvement in overall survival. So here you can see the hazards in PFS in Paloma trials in terms of PFS is close to 0.6, 0.5. Very impressive. But if we see the overall survival hazards, they are nearing 1 or 0.8 and again were not significant. So there were three kind of hypotheses as to tease out why there is this difference. One, as I said earlier, is this due to different patient population in the trials? Or second, is it different because of use of different strategies after progression on these molecules in the trials? Like once they have progressed in the trial, they are given subsequent treatments of trial, whether that has made any difference, or these molecules in themselves are different. So we'll see one by one. This is something interesting in terms of comparing ribociclib and palbociclib. What they have done is kind of a statistical maneuver only by using something called as matching adjusted indirect comparison, where two trials, two they have studied. There were some differences in terms of how the patients were recruited. Patient similar, more, just in excess of 650, but randomization was 1:1 in Mona Lisa and 2:1 in Paloma, and both used letrozole as the companion drug and the comparator drug with palbo or ribociclib. And PFS was the primary endpoint in both the studies. The stratification factors were different, and what was also slightly different in favor of kind of a better patient profile was in favor of ribociclib, that patients who had a treatment-free interval of less than 12 months were slightly lower, marginally lower than the Paloma trials. So if we are having a patient population which has a longer treatment-free interval from the previous therapy, the way we describe endocrine resistance, I think it will be a slightly better patient population. So a complicated maneuver they did in terms of matching the patients, and then after matching those patients, the patients that were included from the Mona Lisa trial were only 260 out of 660 odd. So 400 patients were excluded because they would not have been included in the Paloma trial as per their inclusion criteria. But these patients were kind of match that number of trial data. So complicated kind of mathematical maneuver. And what they showed that once they do all, even then the PFS and OS was in favor of ribociclib. So again, this maneuver showed that maybe different patient population may not have made much difference. I know, I understand that this is not the direct head-to-head comparison or randomized study, but this is possibly, at least as of now, the best possible option. And we may not be able to get a randomized study now once they are getting off patent anyway. So was there any difference in the post-treatment progression treatment? So there is a pooled analysis of post-progression treatment of all the three Mona Lisa studies, 2, 3 in post-menopausal setting and 7 in the pre-menopausal setting. And they were compared with Paloma 3, which may not be the best comparison because Paloma 3 is kind of only second line, whereas we are also taking the first line patients in Mona Lisa 2 and some in 3 as well. So, so the most common subsequent therapy, if we see the placebo arm, usually that is chemotherapy. Whereas if we are seeing the ribociclib arm, chemotherapy is not the most common treatment.
Dr. Kunal requests you to conclude in next 2 minutes.
Yes, madam.
Please. Okay.
And what it is was showing that, like we see with tamoxifen as a carryover effect, patients who were given ribociclib, their second line treatments were slightly longer than the other placebo group. So just indicating that there possibly may be some carryover effect of ribociclib leading to a longer second line treatment as well. And is there any different pharmacological characteristic? So CDK4 and 6, they may have differential activity actually on these two parts of the cell. The ribociclib and abemaciclib are more active against CDK4 as compared to CDK6. And that is why their CDK4 has a more important role in breast, whereas CDK6 in the myelosuppression or the bone marrow may be more important. And they have fewer ribociclib and palbociclib have fewer interactions with off-target kinases than abemaciclib. And even the drug concentration at lower level can achieve, in terms of ribociclib, can achieve better results. So there is some difference in pharmacological characteristics of these agents, which are kind of more in favor of ribociclib in terms of lower dose, achieving adequate benefit and lesser toxicity as compared to abemaciclib, which is the other more preferential CDK4/6 inhibitor. So guidelines do recommend, because of this overall survival benefit, now the updated guidelines do give ribociclib an edge in terms of category 1 recommendation, either in combination with the aromatase inhibitors or with fulvestrant. And even the ESMO magnitude of clinical benefit scale puts ribociclib on top in terms of benefit. And there are different treatment, different groups of patients with visceral mets, liver mets. All of them had shown that ribociclib was showing significant improvement. And even if we do dose reduction, even those patients derive kind of similar benefit, dose reduction due to any of the toxicities. Majority of the times it is hematological toxicities. And similarly, is ribociclib showed benefit in patients with CNS metastasis. This is also not very common in ER positive, but it is kind of a difficult subset to treat. And we always talk about large volume or large burden of disease, and sometimes patients nearing visceral crisis or in visceral crisis. And this study, Right Choice, basically looked at comparing ribociclib with the AI and the goserelin in premenopausal patients with either any of the chemotherapy regimes, which was based on investigator's choice. And what it showed that there was a significant improvement in PFS, almost doubling of PFS with a significant p-value and hazard of 0.5, and kind of similar responses and duration of response, or like the time to first response assessment also was numerically maybe longer, but it was not statistically very significant or poorer in terms of ribociclib. So it was comparable. You would expect that chemotherapy would work faster. I'll just conclude with this SONIA study, which was presented in ASCO this year by the Dutch group, where what they were looking at is, because of these molecules being very expensive, causing a huge burden to the taxpayers, whether if we reserve CDK4/6 inhibitor and use it in second line, whether it will be give the same benefit. So they were using non-steroidal AI with CDK4/6 inhibitor, or only aromatase inhibitor earlier, and then adding CDK4/6 inhibitor in second line at progression. So obviously PFS1 was longer in favor of CDK4/6 inhibitor, but when they looked at PFS2, numerically it may be longer for that subgroup of patient where CDK4/6 inhibitor was used in first line, but it was not statistically significant. So what they were saying, overall survival was not different. And there was a 16 months extra of CDK4/6 inhibitor, which was given if it was used in first line, and which meant that extra cost of about $2 lakh if we see the cost of CDK4/6 inhibitors, which is there abroad. So all the context, the idea was that even if we give CDK4/6 inhibitor in the second line, it may not be that detrimental. But the majority of the patients that got CDK4/6 inhibitor was ribociclib. So summarizing, CDK4/6 inhibitors significantly improve OS across lines of therapy and endocrine partner and menopausal status. Ribociclib also has demonstrated consistent efficacy across patient subgroups, including high tumor burden, visceral mets, and more than 3 metastatic sites. And now we have data from Right Choice showing that even in kind of visceral crisis, some of those patients where we may be finding chemo difficult, we may be able to treat them with this combination. So this is the only CDK4/6 inhibitor with proven PFS benefit, response rates, and time to response when compared with chemotherapy in this aggressive disease subset population. So I think with that, I'll end. And among all the CDK4/6 inhibitors, it is mainly that survival benefit, overall survival benefit, has tilted the scale in favor of ribociclib.
Thank you, sir. So, as per the data available, so Daibo has an edge above the other CDK4/6 inhibitors, and maybe in the adjuvant setting, a trial, the results are still out, are not out. Like the abemaciclib, ribociclib may also show a result for the patient in the adjuvant setting. So next,
when the adjuvant setting dose they are also using is 400 milligrams. So we do not know whether 400 is as good as 600.
Yes. Thank you, sir. So Ashwin, you are there?
Yeah, Jagdeep, I'm here.
So next topic is by Dr. Ashwin Phillips. He is medical oncologist at Oswell Hospital, Ludhiana. So he will be talking about the trastuzumab deruxtecan in metastatic CA breast HER2 positive. Over to you, Ashwin.
Yeah, thanks, Jagdeep. Are you able to see my slide? One second. Where is the share option? Right. Is the slide visible?
Still, yes, yes.
Yeah. So I would like to thank Jagdeep for giving me this opportunity, and without wasting much time, I'll get on to the discussion. Yeah. I'm able to minimize the screen. Yeah. So we're going to talk about recent advances in metastatic HER2 positive breast cancer, and again, I wouldn't waste too much of time talking about the basics of this topic. Going ahead with it. The slide not moving. Yeah. So all of us know the basics about it. We know that roughly around 30% of your patients would have a HER2 positive breast cancer, and at some point of time, most of the patients would turn to be metastatic in Indian setting. So there's this landmark thing that Dr. Sleiman and Davis did, was to identify the HER2 overexpression and to develop a drug called trastuzumab. And it's one of these drugs that revolutionized the way we treat patients, and one of the first targeted types that is approved in 1998. Now, we all know this, that whenever we have a disease that is driven by a target or by a protein, it's important to switch off the protein to treat your patient. So the concept is very clear nowadays in breast cancer. If you have your option of giving a targeted therapy, it has to be given upfront. And the options that you have right now are going to be, if you look at the first line options, it is trastuzumab. If you can use it, you can use it with pertuzumab. So the Cleopatra study showed you the use of trastuzumab with pertuzumab combination, and my slides are moving fast. Yeah. So this was very clear. You had this THP versus TH, and showed you the benefit of adding a pertuzumab combination to standard of care docetaxel and trastuzumab. And what you had is that the median PFS was increased by 6.3 months. The median OS was significantly improved by around 16 months. And the toxicities were slightly higher in the THP arm versus TH. But this was something that was significant, and one of the landmark studies that showed us that yes, combination of trastuzumab pertuzumab was an important thing in these patients. If you look at the second line therapy, you were left with options like what you had in the Emilia study, which looked at TDM1, and that brought up TDM1 versus capecitabine and lapatinib, showing you that if you use TDM1 was as compared to capecitabine and lapatinib, the response rates were higher, and the median survival Median overall survival was 9.6 months or 6.4 months. The PFS was 9.6 months versus 6.4 months. And the overall survival was 13.9 months versus 25 months. So again, it showed you the best way at that point of time was to use, if you could use TDM, if you could use THP would be the first line, and the second line would be TDM1 over capecitabine and lapatinib. Now, what you need to understand is that if you were trying to use THP and you were trying to give TDM1 later on, the PFS dropped by a significant half, by around 50%. So you need to understand both the Cleopatra and the Emilia studies we conducted simultaneously. The publications was almost similar. But what you need to understand is that probably what the real world data shows is that if you use trastuzumab and pertuzumab together and then you use TDM1, you may have significantly worse PFS. There are two studies which looked at it from that direction, and one of the studies showed a conflicting report showing that if you had used THP upfront and used TDM1, the survival could be worse than your standard therapy. So this is probably the reason why they discuss about this. Is the thing is, if you use a doublet, that is a trastuzumab and pertuzumab combination, you may have lesser expression of your HER2 expression, and thus the TDM1 activity may be reduced. So this is theoretically what is supposed to say, but in a real world setting, there's not much of data. There's no phase 3 study showing how to best sequence this therapy. Yes, in most of our circumstances now, considering the fact that pertuzumab is still expensive, a rational thing would be to use trastuzumab followed by TDM1, especially if you can afford the generic version of it. Now, if you look at the recent advances, that is the main crux of my topic, is to look at, like I said, the way we have moved ahead. For a long time, we've been stuck with trastuzumab, pertuzumab, then you come into the capecitabine, lapatinib. TDM1 is a remarkably good drug. But from 2019 onwards, you've had this trastuzumab deruxtecan that has come into the picture. You have got neratinib to tucatinib coming in, and margetuximab that is coming in 2020. So if you look at this trastuzumab deruxtecan, there's a lot of discussion about this drug. It is quite similar to your TDM1. It is an antibody drug conjugate. What it has is a highly potent topoisomerase inhibitor payload. It has a cleavable linker, and it combines 8:1 drug to antibody ratio. So what happens is, just like TDM1, it leads to the release. There's internalization of your drug because it binds to the HER2. Once it is internalized, the cleaver gets cleaved, releasing the topoisomerase inhibitor directly. It's like a guided missile, and highly potent. And so what it showed you, that it showed a very good response in patients, as much as 60% of patients who are treated with who are heavily treated showed a response of this drug. Now, if you compare between TDM1 and trastuzumab deruxtecan, what you could see is that there's a higher drug to antibody ratio. The cleavable linker is tumor selective, and there is very little anti-tumor effect, bystander effect of the anti-tumor effect. Now, if you look at the Destiny series of studies, which are very important, you have the Destiny 02 study, Breast 02 study, which looked at trastuzumab deruxtecan versus a physician's choice of trastuzumab capecitabine or capecitabine lapatinib, where the randomization was 2:1, and these patients were previously treated with metastatic HER2 positive breast cancer. And if you look at this subset of patients, where the primary endpoint was a PFS and the secondary endpoint was OS. And if you look at the study, if you look at the baseline demographics, they were almost similarly matched in both the arms. There was a 2:1 randomization of this study. And what you see here is that this is remarkable. This is usually going to be something remarkable. If you look at 12 months, the treatment arm had a PFS of around 62% versus the treatment choice of 27.2 in the comparative arm. So what you had here is a median PFS of 17.8 months versus 6.9 months, which is remarkable, with a very healthy hazard ratio of 0.35 and a very significant p-value because of it. If you look at the secondary endpoint, that was the overall survival. Again, not only did the PFS show a remarkable improvement, the 12-month overall survival was 89% versus 74%, and at 24 months it was 65 versus 54%. So if you look at the median overall survival, your treatment arm had 39.2 months versus 26.5 months. Again, a very significant hazard ratio. So to conclude, if you look at the Destiny 2 study or the Destiny Breast 02 study, the use of trastuzumab deruxtecan significantly improved your PFS and OS versus the physician's choice of patients with HER2-positive breast cancer. This included patients who were treated with TDM1 in the past as well. Now, the overall safety profile was consistent with the established safety limits of trastuzumab deruxtecan, and this showed you that yes, you had an option after your trastuzumab, pertuzumab, TDM1, and this is the next drug that came up into the picture. Now, since the drug did so well, it is important to see whether this drug would be better than TDM1 also. So then came the study, the Destiny Breast 03 study, which is again an open-label multi-centered phase 3 study. Again, previously multiple lines of treatment down the line. Patients in this study were allowed to have brain metastasis if they were stable, and if they had received radiation, they had to wait for a period of 2 weeks. And then the randomization was 1:1 between trastuzumab deruxtecan versus TDM1. Primary endpoint is PFS, and secondary endpoint is overall survival, with secondary endpoints of objective response rate and PFS was looked at in this study. Now, if you look at it again, what is significant here is that majority of the patients were from Asia. That's 60% of the patients. Again, most of the trials that we have don't have an Asian population of patients. So you had 60% of the patients coming from Asia. And if you look at this, like we discussed before, they were similarly matched in terms of brain metastasis. Around 20% in each arm had brain metastasis. So if you look at the previous anti-cancer therapy, they were almost similar, with patients receiving pertuzumab, trastuzumab in most of the patients, and majority of the patients were receiving it in the first line therapy. So what you saw here is if you compare TDM1 versus trastuzumab deruxtecan, there was a remarkable improvement by using trastuzumab deruxtecan with a 12-month PFS of around 75% versus 33%. That is almost double the PFS, and a very healthy double of the PFS, with hazard ratios only 0.33 with a very significant p-value. So at 24 months, it was 53% versus 26%. Now, if you look at the secondary endpoint, which is the objective, again, you can see that the curves separate very early on, and this continues to be separated toward the entire period of time. So we're showing a very good improvement by using this drug in the second line rather than the third line. If you look at the overall survival also, the PFS benefit goes on to extend into the overall survival, where you have the median overall survival of 40.5 months versus not reached, and hazard ratio 0.64 months. Hazard ratio 0.64, which is the healthy confidence interval. So which showed you that this drug not only showed you a very good PFS benefit, it showed you a very good OS benefit as well in the second line after your trastuzumab, pertuzumab. Even if you could afford this drug, this would be coming up right ahead of your TDM1. If you look at this forest plot, what you can clearly see is the benefit of this was markedly across every subset, including the hormone receptor positive, negative, the prior use of pertuzumab, the presence of visceral crisis, the number of lines of chemotherapy in the past, and the presence of brain metastasis, showing you the very efficacy of this drug in this setting. Now, if you look at the overall survival in all this subgroup analysis, also shows you that this was remarkably better than TDM1. Now, if you look at those patients with and without brain metastasis, if you look at those patients with brain metastasis at the baseline, again, the curves are very separating right at the beginning. And even without the brain metastasis, this drug was going to be very effective. Now, if you look at the objective response rates, again, showing you that this drug was very effective. You can see the objective response rates were much markedly better than just using TDM1. Now, one interesting study that you understand that most of the times that we study about these patients is that today we talk about PFS2, that is a disease progression, the time to disease progression after second line therapy. What you would see here is the median PFS2 is around 40.5 months versus 25 months, which is again almost double of what you would expect with TDM1. So again, showing you the fact that these drugs are highly effective and they have long-term benefits rather than short-term. Look at the overall survival. If you look at the median duration of treatment, it's around 18.2 months versus 6.9 months. And the most common toxicity that you would expect was pneumonitis, ILD, and pneumonia. Whereas with TDM1, you would expect, as expected, the platelets counts to drop, pneumonitis, and thrombocytopenia. Now, if you look at the main side effects, yes, you could expect some amount of anemia, which was again part of the previous. There was nothing new to say what could be alarming about the use of this trastuzumab deruxtecan. The worrying thing would be pneumonitis and lung disease in ILD. So if you look at the longer duration of exposure, then the chances of your lung issues increase from 10.5 to around 15% the PFS analysis. So yes, if you look at toxicities, you're more going to be more worried about of pneumonitis and ILD in these subset of patients. So if you look at the the ESMO 2022 update, which shows you the benefit of using this drug, showing you that the benefit is markedly better if you're going to use trastuzumab deruxtecan. And to conclude, there's no question if you look at the Destiny studies that, the use of trastuzumab deruxtecan was shown improvement within overall survival benefit over TDM1, as well as PFS benefit in patients who were previously treated with trastuzumab and taxane. And this overall survival benefit was consistent across all subgroups. And this drug showed not only a PFS1 benefit, a PFS2 benefit in the subset of patients as well. So this is what you would conclude in this patient, saying that if you look at the Destiny 3 study, it showed you that yes, if you can sequence your treatment, the best way would be trastuzumab, pertuzumab upfront, and second line, if the patient can afford, and if it's available in India, would be to go for trastuzumab deruxtecan rather than for TDM1. Now, tucatinib is a drug that has been again discussed a lot in these studies as a HER2 climb study, which looked at those patients who had again two randomization, 2:1 randomization, 2 arms, with tucatinib, trastuzumab, and capecitabine versus placebo, trastuzumab, and capecitabine. Again, these patients with treated brain metastasis with stable diseases. And what you can see here is a combination of trastuzumab, tucatinib, and capecitabine showing you a benefit over just your trastuzumab and capecitabine. So what you would see is objective response rates of 41% versus 23%, and a median PFS of about 7.8 months versus 4.9 months, median OSS of 21.9 versus 17.4. Again, the grade 2 toxicity was slightly higher if you look at tucatinib versus the placebo arm. And if you look at the median PFS and the overall survival, in both the ways, the drug was better than your placebo arm in this subset of patients. Now, if you look at those patients who had brain metastasis, you can see that the curves separate pretty late, but in spite of that, what you would have is that you would have a significant PFS and an OFS benefit by using your tucatinib trastuzumab combination. Now, if you look at the overall survival, again, if the updated overall survival shows that the benefit is still persistent, and it is not at 1 year, 2 years, it's still benefit shows you the PFS, and the also shows you the control in the intracranial progression in these drugs of patients as well. So you did have side effects with these drugs, but what do you call it? The majority of the side effects were low grade, and discontinuation of the drug only was seen in around 5.3% of the patients, and death because of toxicities was only seen in 1.5% of these patients. Neratinib, again, a drug that has been discussed extensively. The NALA trial looked at neratinib plus capecitabine versus cape-lapatinib combination in patients who were HER2 positive metastatic breast cancer, but got more than 2 lines of therapy. Again, it was a 1:1 randomization with neratinib on one arm, with capecitabine on the other arm, and cape-lapatinib on the other arm. Again, what you see from the baseline chart is that patients would have received trastuzumab combination, pertuzumab combination, and a combination of patients receiving pertuzumab, trastuzumab, and TDM1 as well. Now, the median PFS was 8.8 months versus 6.6, with no significant difference in the overall survival. There may have been slightly higher CNS penetrativity, but the higher toxicity was there, especially with the known toxicity of diarrhea. Now, coming to this megestutimab, which is again a very important molecule, again discussed in patients who had post multiple lines of therapy, the SOPHIA trial. This subset of patients had at least 1 to 3 lines of prior therapy in the past and the metastatic setting. They were randomized 1:1 into a physician's choice of therapy versus the treatment arm. And the primary endpoint was PFS and OS, and the secondary objective endpoints were objective response rates and safety and tolerability. What you see here is that if you look at the primary PFS, you have a 5.8 month versus 4.9 months. Please understand this is post multiple lines of therapy, again with a hazard ratio of 0.76, with a slight benefit with a p-value of 0.03. Now, if you look at the OS, the OS did not show a major survival advantage in the intended treat population. There has been some exploratory subgroup analysis showing that patients with CD16A 158F allele had some benefit. Again, these are not treatment analysis, so it is difficult to get into this. So I wouldn't say that this would be showing an overall survival advantage, but showing you that this is one of the treatment options that you have in the long run. So to cut it short, what you need to understand is that if you have an option of treating metastatic CA breast HER2 positive, your first line options would be pertuzumab, docetaxel, trastuzumab, or a doublet with paclitaxel. Or the second line options would, if you can afford, would be definitely would be trastuzumab deruxtecan also over TDM1. And the third line options you would be exposed to tucatinib, lapatinib, or TDM1. It depends on the sequence, but if you can afford, that's the best way to take it forward. Would be to sequence it with TPH initially, followed by trastuzumab deruxtecan. Now, just a discussion about what is being so hotly discussed in most of the meetings nowadays is a low HER2
So
subset of
Ashwin
patients.
requests you to conclude in the next
Yeah,
minute.
so with that, I would like to take it up and thank the sponsors. Thank you.
Dr. Ashwin, and this TDX has taken an edge of the TDM, and that's why I come to the second line, the metastatic CA breast. And the main concept on rational is the high payload and the ADR ratio. That is the basically ADR ratio. That's the most important thing. And the patient who had a CNS metastasis, tucatinib or this TDX, that has given some impact to their future. And Destiny trial has really proved that their destiny has changed the patient who have received this TDX. But they should be having stable brain metastasis. But in our setting, we usually don't see those types of patients. Patients usually come with a progression, and they usually are same symptomatic. So means maybe now the population is 60% of the Asian population patients who are using these drugs in those trials. But if you see the real world data, we will be using those patients, this drug patient who will be symptomatic for the same. Anything you would like to say, Dr. Ashwin?
Yeah, see, even though I said 60% of the patients were from the Asian population, understand that I don't think Asia, our subset of patients are behaving typically like them. We are generally a bit more different. But that is the reason that I say that a lot of trials need to be done from our subset of patients as well, collect our data and then look at how our patients also behave technically from the rest of the people. In a practical sense, to be very frank, because of the affordability, most of the patients will get trastuzumab combination upfront, and then in the disease progression, it would be TDM or the generic that can make more sense if you can afford it. And that is the way we would look at it in Indian subset of patients.
Yes,
but most of the time, I keep trastuzumab as a backbone and continue something else like capecitabine or something which is reasonably feasible to do in Indian subset of patients because they do also have some benefit.
Yes, agree with you. Thank you, Ashwin.
Yeah, thanks.
So next topic will be Dr. Devinder. So Dr. Devinder is a medical oncologist at Fortis, Ludhiana. My colleague at DMC Ludhiana initially. Over to you, Dr. Devinder. And your topic will be the dual anti-HER2 therapy, FASCO, in CA breast.
So good evening, Dr. Jaydeep. How are you?
Fine, doing good. Missing you.
Same feeling. So thank you, Dr. Jaydeep, and thank you for the organizers for inviting me for this short talk. So can somebody please share my slides? So I am having a difficulty from my side.
Yeah, just wait for a second, sir. I'm sharing.
So as Dr. Ashwin has already told, we have so many drugs right now for the treatment of HER2 positive disease, especially in the metastatic setting. So my role would be to give the overview of the transforming journey of our HER2 positive breast cancer patient treatment. Next slide. So these are the disclaimer. So regarding the first line treatment, we know that Perjeta, that is pertuzumab and trastuzumab, has a role in every setting, whether it's a neoadjuvant setting, adjuvant or metastatic setting. In the neoadjuvant setting, this molecule had a trial called the NeoSphere trial, in which the addition of pertuzumab to the combination of trastuzumab and chemotherapy significantly improved the pathological CR rate from 31 to 49%. And in the adjuvant setting, in the early breast cancer patient at high risk of recurrence, the affinity trial showed that the addition of pertuzumab to this combination reduced the risk of recurrence or death by almost 23%. And especially in the node-positive early breast cancer patient, this reduced the recurrence of death by almost 28%. And of course, most of our patients in the metastatic setting, in the first time metastatic setting, the Cleopatra trial showed that the addition of pertuzumab to this combination significantly increased the median PFS from 12.4 months to 18.5 months. And the median OS was also significantly increased from 40 months to almost 56.5 months. So the addition of pertuzumab to trastuzumab and chemotherapy is approved and recognized by the international guidelines as the standard of care in setting in the patient of HER2 positive breast cancer. Next slide. So this is just an overview. A newly diagnosed HER2 positive early breast cancer patient, if the tumor size is less than T1, also the patient go for surgery. If there is no nodal involvement, we could just continue with the trastuzumab and maintenance. If there is node positive, the recommendation is to give a combination of pertuzumab and trastuzumab. But if the tumor size is more than 2 centimeters, and if we have a nodal disease, we give NSCT with dual HER2 blockade with including pertuzumab and trastuzumab followed by surgery. And if we achieve a pathological CR, we just continue with this combination of pertuzumab and trastuzumab. But if there is a residual disease, now we have a standard of care that we have to give 14 cycles of TDM1. Next slide. So IV infusion of pertuzumab and trastuzumab is well established, but there are certain challenges because it requires a long infusion and observation time. For pertuzumab, it is infused of 60 minutes and followed by observation of almost 60 minutes. And similarly for trastuzumab, infusion of around 30 to 90 minutes and observation for around 2 to 3 hours, 2 to 6 hours. And there is IV preparation time is longer than for subcutaneous formulation, and it requires more accelerated resources. Of course, we require indwelling venous catheters like the chemoports or the PICC lines, which have increased risk of infection, thrombosis, or discomfort, especially in the setting, in our setting of resource constrained setting. And in some patients, establishing IV access is also sometimes it's a cumbersome job in some of the patients with poor venous access. Next slide. So Phesgo is the first formulation in oncology to combine two monoclonal antibodies, that is the pertuzumab and trastuzumab, in one vial for subcutaneous injection. It contains the same antibodies as approved for the IV pertuzumab and trastuzumab, but has a different route of administration. It is formulated with a recombinant human high hyaluronidase to allow the subcutaneous administration of a higher drug volume, that is 15 ml loading dose and 10 ml maintenance dose, and is ready to use fixed dose formulation and is administered by subcutaneous injection in the thigh over approximately 5 to 8 minutes. Next slide. So basically, these molecules are already there. Pertuzumab and trastuzumab fixed dose combination, but the addition of hyaluronidase is an endoglycosidase, which is used to increase the dispersion and absorption of the co-administered drugs. So this molecule allows the subcutaneous delivery of large drug volumes. It increases the permeability of the subcutaneous tissue by depolymerizing the high alloron based on the preclinical studies. And the effect of these enzymes are reversible, and the permeability of the subcutaneous tissue and the skin is restored within 24 to 48 hours. Next slide. This is just a slide showing that the subcutaneous layers contains a matrix of higher hyaluronate fibers and the collagen fibers, which limit the subcutaneous administration of volumes of less than 1 ml. But the addition of hyaluronidase to this Phesgo temporarily and locally degrades this molecule at the injection site with no changes in the structure of the underlying tissue. And the degradation of hyaluronate results in temporary increase in the local subcutaneous dispersion area and enabling the larger volumes of fluid to be administered. So the formulation of hyaluronidase allows the subcutaneous administration of a larger volume, that is more than 1 ml. Next slide. You can see from this slide on the left side, without using this enzyme, before infusion and after infusion, you can see there is a large lump formation on the skin. But if we use this enzyme, you can see even after administration of this drug, there is no formation of any swelling or any pain at the site of subcutaneous injection. Next slide. So does Phesgo have the same pharmacokinetics, efficacy, and safety as the IV formulation? Next slide. So there was a trial called the BO30185 phase 1B study. It was performed in the human male volunteers followed by the early breast cancer patient. And in this patient, the recommended dose of Phesgo was loading dose of 1200 milligram of pertuzumab and 600 milligram of trastuzumab, followed by maintenance dose of 600 milligram each of pertuzumab and trastuzumab. And they were all the parameters taken into account, the PK, efficacy, safety, and preferences. Next slide. This is just a plot of the trial. You can see on the left side there were multiple cohorts. Cohort 1, 2, 3, 4. Cohort 1 was just Perjeta IV. 2, 3, 4 was the subcutaneous pertuzumab, and the cohort 5 was the subcutaneous trastuzumab, and the cohort 6, 7, 8 was the combination of subcutaneous pertuzumab. These are all done in the healthy male volunteers, and then they were taken up to the early breast cancer patients. Next slide. So what is the summary of this trial? The PK and dose finding. So this trial selected a loading dose of 1200 milligram pertuzumab and maintenance dose 600 milligram of pertuzumab, and the PK data in the healthy male volunteers and patients with early breast cancer predicted that these doses will result in equivalent pertuzumab serum exposure to that of IV Perjeta. And the dose finding process used to find the subcutaneous dose of pertuzumab was similar to those used successfully in the development of both subcutaneous Herceptin and subcutaneous Mabthera, that is the rituximab. So safety, there was no safety signals observed for the subcutaneous pertuzumab, and the PK and safety results further supported the development of this molecule. Next slide. There was another trial called the Phi-Derica trial. This is phase 3 non-inferiority study assessing the PK efficacy of these two molecules, that's the PESCO and the IV formulation. You can see the patients were locally advanced inflammatory or had two positive breast cancer. They were randomized to 2 arms of chemotherapy, and after after chemotherapy, 1 arm was given the IV formulation, other arm was given the subcutaneous formulation followed by surgery. And later on, maintenance was similar. That is, IV formulation was continued with the IV maintenance, and subcutaneous formulation was continued with the subcutaneous of the maintenance. The primary endpoint was the non-inferiority to the cycle 7 plasma serum trough concentration and of the pertuzumab, and the secondary endpoint was the non-inferiority of the cycle 7 human trough serum concentration of the trastuzumab. The pathological CS safety data, event-free survival, disease-recurrent survival, and the OS. Next slide. So this slide showed that if we see 3 parameters, that is the serum trough concentration, AUC, the area under the plasma serum concentration, and the Cmax, all these parameters are equivalent. And for some of the parameters, the subcutaneous formulation was even better than the IV formulation. Next slide. So you can see PESCO was non-inferior to the IV formulation based upon the cycle 7 pertuzumab and the trastuzumab serum trough concentration, and they were equivalent in both the arms. Next slide. Similarly, identical PASI were obtained with the IV and the subcutaneous formulation, almost similar, 59.5 to 59.7, and even depending on the body mass index also, it was quite comparable in both the arms. Next slide. Safety profile, even the safety profile also, the rates of treatment discontinuation due to AE was similar. Any adverse events, whether it is grade 3, were also comparable in both the arms. There was 1 death in the IV formulation due to the sepsis, and the 1 death in the PESCO arm due to myocardial infarction. Next slide. Most common adverse event incidence of AEs were also consistent with the other studies that included the IV arm. You can see all the common side effects, elevation, which is the drawback of the concomitant chemotherapy, other like nausea, diarrhea, anemia, and cystinuria, they were also comparable in both the arms. Next slide. And the incidence of adverse events of interest, including the cardiac dysfunction, infusion reaction, after infusion reaction, hypersensitivity, were also comparable in both the subcutaneous and the IV formulation. Next slide. And there was no meaningful difference in the cardiac, which is the main concern with the use of anti-HER2 molecules. There was no meaningful difference in the cardiac safety between the treatment arms, whether it's the primary cardiac events, secondary cardiac events, or the LVEF decline. They were all comparable in both the IV and the subcutaneous PESCO arm. Next slide. So the PESCO was non-inferior to pertuzumab, IV pertuzumab and trastuzumab based upon this serum trough concentration of both the pertuzumab and the Herceptin. The pathological CR rates were almost nearly identical with the subcutaneous and the IV formulation, and the safety profile of the subcutaneous formulation was comparable to that of the IV formulation. Next slide. So do patients prefer IV or the subcutaneous formulation? Next slide. So there was a study called the French SCS study, phase 2 study, in which patients were initially randomized to IV or the subcutaneous form, and later on the IV was shifted to subcutaneous, and the subcutaneous was shifted to IV. And later on, after completion 6 seconds, the patient was given the choice whether they want to continue with the IV formulation or subcutaneous formulation. Next slide. So in this study, it was seen that the preference for the subcutaneous PESCO was very or fairly strong for the majority of patients. The main reason for subcutaneous preference was less time in the clinic, more comfortable during the administration, and almost 87% chose PESCO as compared for the continuation of treatment. Next slide. So similarly, treatment had no impact on the patient on the healthcare professional speaking time, and most patients had more than enough time to talk to the healthcare professional during the treatment of the subcutaneous formulation as compared to IV formulation. Next slide. So even the majority of healthcare professionals felt that switching from the IV to subcutaneous form would save time and resources, and almost 90% of the healthcare professionals thought that the PESCO was quickest, and almost 87% thought that it required less resource uses, and almost 80% of the doctors, they agreed that the subcutaneous formulation resulted in less drug wastage. Next slide. So AE rates before and after switching was similar. That is, even if you switch from IV to subcutaneous, there was no addition of any adverse events. Next slide. So this study showed that the main reason for subcutaneous preference was the less time in clinic, more time comfortable and patient being more comfortable during administration, and more patients were very satisfied with the subcutaneous arm, and most patients indicated that treatment had no impact on the amount of time they had to talk to their doctor or nurse. and while receiving treatment, they had more than enough time to talk to their doctor. And even the doctors also indicated that the Phesgo had marked time saving and saves lot of resources as compared to IV formulation. And as far as safety is concerned, it is well tolerated, and there is no additional safety profile as compared to the IV formulation. Next slide. So regarding the practical consideration for using Phesgo in the real world, next slide. So this is I'll not go to the detail because this is primarily for the nurses and the daycare staff. But the important thing to see is that it has to be given in the thigh area, and we do not split the dose between two syringes or between two sites of administration. One thigh is used for one injection, and the next time the patient comes, the next thigh is used. And next slide. And this is just showing that we have to pinch the skin, make an angle of almost 30 degrees, and we have to infuse the drug over a period of 5 to 8 minutes. Next slide. And this is just for the daycare staff to for their purpose. Next slide. So what would Phesgo mean for the patient healthcare professional? Next slide. So it has a short administration time, 5 to 8 minutes, and observation period just 15 to 30 minutes for Phesgo. It reduces the burden on the patient's carers and the providers. It is less invasive administration, single subcutaneous injection versus the IV, 2 separate IV infusions, freeing the patient from the burden of IV-related pain, bruising, tradition. Fixed dose formulation may help reduce the risk of dosing error, reducing the drug wastage, and increasing the availability of nursing and pharmacy staff for other tasks. Reduced time required for the drug preparation administration with Phesgo as compared to the IV formulation has the potential to relieve strain on the infusion centers. And of course, there is no new safety signal that has been observed when switching from the IV to the subcutaneous Phesgo and vice versa. Next slide. So first formulation in oncology to combine 2 monoclonal antibodies in one vial, and the Phesgo has cycle 7 pre-dose, cycle 8 pertuzumab, and Herceptin serum trough level concentration and incidence of adverse events. They are comparable in both the arms, and the pathological CR rates were almost identical between these two arms in the intent to treat population and were not impacted by the body mass index. Next slide. So majority of the patient preferred Phesgo, almost 85%, regardless of sequencing, and felt that Phesgo had no impact on the patient healthcare professional speaking time. And even the majority of the healthcare professionals thought that switching from IV to subcutaneous injection would save time and resources during preparation and treatment. So now Phesgo is now the FDA and EMA approved for the same indication as the IV per data.
Yashika, Nishan, for making this event successful. Thanks all.
Thank you, sir. Thank you, everyone, for joining. Thank you,
sir.
Nishant. Thank you, Yashika. Thank you, support team. Good night, everyone.
Yashika, I'll put the message to you on that for the 8th of October.